Good evening, doctors. We are Group 2, and we will be reporting the return demo forecasting. Next, please. So for our objectives, we would demonstrate proper focus history and PE of patients with a suspected fracture, identify appropriate radiographic imaging tests for patients with fracture, formulate the diagnosis based on the findings from history, PE, and imaging tests, discuss different immobilization techniques and indications for applying circular cast and posterior mold splints, discuss basic steps in applying circular cast and posterior mold, demonstrate proper focus history and PE of patients with suspected fracture, identify appropriate radiologic imaging tests for patients with fracture, formulate a diagnosis based on the findings from history, PE, and imaging tests, and discuss different immobilization techniques and indications for applying circular cast and posterior mold splints, and discuss basic steps in applying circular cast and posterior mold. Next, please. So here is our case. We have AP, 58 years old, female from Rizal, known hypertensive and diabetic. Her chief complaint is right forearm injury. Next, please. Our HPI is few hours prior to consultation. The patient was sweeping their backyard when she slipped and fell on her right hand. She noted severe pain and swelling in her right forearm. She had no loss of consciousness. She was brought to a nearby hospital where she was given anti-tetanus medications. She was also prescribed with sulfuroxime 500 milligrams per capsule twice a day for 7 days and an NSAID. She was then referred to our institution to be seen by a specialist. Next, please. Her view of symptoms: she has no fever, no cough, no colds, malaise, nausea, vomiting, lightheadedness, nor urinary or bowel changes. Her past medical history: she was known hypertensive and she's taking propranolol. She is also known diabetic and taking metformin. Her personal history is she was a housewife, she is a six-pack year smoker, non-alcoholic beverage drinker. Next, please. Her family history was unremarkable. Her physical exam: patient is awake, conscious, coherent, not in distress, came in with an arm sling on right arm, and ambulatory. Her vital signs was blood pressure 130/80 millimeter mercury. Her heart rate was 89 beats per minute. Her respiratory rate was 19 cycles per minute, and temperature was 37.3 Celsius. Next, please. In her right upper extremity, there is a swelling and deformity in the right forearm. There is also 1 centimeter wound with oozing blood in the ulnar border of the distal forearm. She was able to move the fingers, no sensory deficits, and there is a tenderness in the right forearm, and there is full, equal, intact pulses. Next, please. So what other pertinent data would you like to ask from the history? So we would be asking for did the medicines that was given to her provided relief? And next, what is the exact description of the pain? And then since she fell, are there any pain on the other parts of the body aside from the forearm? And does she feel any numbness or tingling sensation? And is she compliant with the current maintenance and medication that was given to her? Next, please. What other maneuvers would you like to add? Next. So first, I will do the hand grip. This is by asking the patient to grasp your second and third fingers. This tests function of wrist joints, the finger flexors, and the intrinsic muscles and joints of the hands. Decreased grip strength is a positive test for weakness of the finger flexors and intrinsic muscles of the hands. And then next would be the fall-in sign. This is for the median nerve compression by asking the patient to hold the wrist in flexion for 60 seconds. Alternatively, then ask the patient to press the backs of the both hands together to form right angles. These maneuvers compress the median nerve. Numbness and tingling in the median nerve distribution within 60 seconds is a positive test. Then we will be checking also for the sensation of the following parts of the hands. We can palp the index finger. Um, this means we will be checking for the median nerve. Then if we will be palping the fifth finger, we'll be checking for the ulnar nerve. Then the dorsal web space of the thumb and index fingers are for the radial nerve. Next, please. We would also like to check for the vascular status in the hand. So of course, we will be checking the pulse of the patients. And then we will do the capillary refill line, which is normally 2 seconds or less. Next, please.
So let's proceed with the radiographs. So the radiograph shows it's a complete dispatch of fractures involving the distal of radius as well as in ulna. So diagnosis are usually require the standard elbow and wrist fracture series of both the AP and the lateral view. In some other case, an additional cross-sectional imaging, usually CT is required to accurately assess the fractures. This is when especially fracture when there is a multiple fracture with joint involvement.
So for the diagnosis, our clinical diagnosis is Galeazzi fracture, distal radio-ulnar fracture of the right forearm secondary to fall.
Good day, everyone. I am Paulo Mangiat, and I'll be reporting guide questions 5 and 6. So first, what is an appropriate treatment at the emergency room? So actually, when we are talking about the emergency care of the injured patient, it is composed of three parts. So first is the first aid, then next is the modus operandi in first aid and management at the hospital. So let us assume that our patient is already at the hospital. So first is we stabilize the patient by doing an initial assessment and management of a trauma patient. So we do a systematic approach. So we do this A to F. So by the way, my reference for my report was taken from the textbook of orthopedics by Eleazar. Okay, so A to F. So we start with your airway management, followed by your blood and fluid replacement, then central nervous system management, digestive system management, excretory system management, and fracture management. So for the initial management at the emergency room, so early irrigation and debridement are the usually the mainstay of the treatment, and the goal is reduction of bacterial count. And usually the timing for this is 24 hours prior to the event. So for irrigation, so saline with castle soap usually decrease primary wound healing problems. And after that, we could also do a wound closure. Usually, you can use simple interrupted suturing for the wound closure. And then for pain management, we give our patient with NSAIDs, and also we can give antitoxins and antibiotics that cover gram-positive bacteria. And after that, we can also use an appropriate radiographs. Next slide, please. So I got this table also from that book. So it tells us on how to be a good first aider. So we can use the mnemonic aid, so alertness, intelligence and decisions. So remember that in first aid, delay is dangerous, and if improperly executed, first aid will become the last aid. Always aid the patient to recovery and do not send him to mortuary by being apathetic. Shifting the patient to a hospital is extremely important, and terminate first aid measure once once medical assistance arrives or after shifting the patient to the hospital. Next slide, please. So next is what is the management plan for this patient and what are the benefits and possible complications of your chosen management. Next slide. Okay, so for first we have a two approaches. So we have a conservative approach and a surgical approach. Now take note that our in conservative approach, it is different in your undisplaced fracture and your displaced fracture. So we focus on a displaced one because our patient has a displaced fracture. So for the treatment for displaced fracture consists of close reduction by traction and counter traction methods under general anesthesia, followed by an above elbow plaster cast. Next slide po. So for the surgical approach, we can use open reduction and internal fixation or your ORIF. So in adults, ORIF is often indicated because it is difficult to regain length, position, axial and normal rotational alignment in adults by closed reduction. And open reduction is usually done by two approaches, one for the radius and the other for the ulna. So the choice of implants for ulna is either a medullary nail or plate and screws, but for fracture radius rigid compression plating is usually desired. Next slide po. So for your intramedullary fixation, these are the indications. We for open fracture with soft tissue injury and or bone loss, as in our patient, and also other are segmental fracture, multiple injuries, failed plating, pathological fractures, and its advantage is less exposure, less periosteal stripping, bone grafting is not required. Next slide po. So for the complications of your ORIF, so we have acute complications and the chronic complications. So for the acute complications, we have a medial radial or ulnar sensory neuropathy, acute and late carpal tunnel syndrome, loss of reduction, stiffness, and painful hardware and tendon rupture. For your chronic complications, we have mild carpal instability and ulnar impaction syndrome. Next slide po. So for the complications of fracture of both bones of the forearm, so we have your Volkmann ischemia. Because of the tight fascial compartment, a patient with fracture of both bones, forearm, is more prone to develop acute compartmental syndrome. Next is your delayed union and non-union. This can be encountered due to soft tissue interposition, inadequate immobilization, and it has to be treated by open reduction, rigid internal fixation, and cancellous bone grafting. For your malunion, due to the complex muscular forces, it is difficult to retain the position of both bones in perfect alignment after close reduction. It is in this situation that malunion commonly results, and it is treated by corrective osteotomy, plating, and bone grafting. For the cross union, this is due to malunion of radial fracture in a medially deviated position, which occupies the interosseous space and blocks pronation and supination. So if the cross union takes place in the middle third of the forearm, it can be left alone as the forearm is held in mid-pronation with less functional damage. Next po.
So for the prognosis of this case, most patients will recover well after surgical fixation of the distal radius fractures and are able to return to their pre-injury work and daily activities. Using a cast and splint to help immobilize the fracture to promote healing and prevent complications. So even after treatment, recovery is often prolonged and rehabilitation is required to regain strength and function. So recovery may last 3 to 12 months when managed properly. That's all. Thank you.
Today, I'm going to show you on how to do a long arm posterior mold. Long arm posterior mold is used for temporary immobilization injuries in the wrist area, forearm area, elbow, and the distal arm area. It is used during transportation for hospital facility or while waiting for definitive treatment. Measure the adequate length of stockinette needed. The stockinette should be at least 2 to 3 inches distal to the tip of middle finger up to the level of shoulder area. For the application of the wadding sheet, again we will make a small hole for the thumb and we will start from the wrist going proximally to the arm. There should be 50% overlap of the wadding sheet. Make sure that you have enough wadding sheet in the elbow area to prevent pressure sores. Next step is to determine the length of the cast needed. We will use wadding sheet as the template for length. Starting from the palm of the hand, we will measure along the metacarpal area up to the distal arm or the supracondylar area. Cut the wadding sheet according to the length measured earlier. Add 2 more layers and another one in the middle and fold it back. Submerge the plaster of Paris a lukewarm water around 20 to 25 degrees Celsius. Make sure that all the bubbles are being dissipated. Just remember, the hotter the water, the faster it to set. Put the plaster of Paris on top of the wadding sheet. Make sure that there are around 8 to 10 layers. Remove all air pockets because it will weaken the mold. Fold the 2 sides of wadding sheet and lastly the middle. Ask the patient or your assistant to hold the proximal part of the cast. Start the application of elastic bandage distally over the wrist area. For the initial application, make it a little bit tighter than the normal so that the plaster of Paris will hold over the patient. Try to mold it a little bit, follow the contour, and wait it to set for 5 to 10 minutes. After the mold has already set, remove the initial elastic bandage. We can now adjust the stockinette. Next, reapply the elastic bandage, and this time, you don't need to apply it in a tightly manner because the patient must be comfortable. Place the body of the sling directly into the injured arm. Now place the shoulder strap across the patient's back and over the shoulder and ensure that the length is in optimum position before securing the strap.